So we have a task group, which I mentioned yesterday, Task Group 79, to develop the ideas on the use of effective dose. And this has been in existence for quite some time, and before that there was a working party. But we now have a first draft of a report, which we've brought to for initial discussion with the main commission and the committees this week. This is, as you can see from the list of members of the task group, very much a cross-committee endeavour. So what I want to do this afternoon is talk a little bit about the three main issues that are addressed within the report. The first is the confusion that arises between equivalent and effective dose. The second is the use of effective dose for different age groups of children and also for the fetus. And there have been some questions over this. And the third is this contentious issue of whether effective dose can be used as a measure of risk. So, as Hans said, the system of protection for the control of stochastic risk uses limits, applies constraints, reference levels, and importantly, optimization below constraints and reference levels. For that you need a quantity, and the quantity that is used is effective dose. And effective dose enables the summation of all radiation exposures to external and internal sources by, as you've already heard in different talks already today, simple risk adjustments using weighting factors, first radiation weighting factors, then tissue weighting factors. It's calculated, as you've seen, in reference phantoms and applies to sex-averaged reference person, and it relates to nominal risk coefficients for uniform external low LET radiation exposure. It's applied without uncertainties, and importantly, there are key assumptions, including the assumption of a linear non-threshold dose-response relationship and the equivalence of chronic and acute exposures, internal and external exposures. So in terms of dose response, we can measure or assess dose reasonably reliably, often very accurately, to very low doses. But of course, the associated risk is increasingly uncertain as we get to lower doses. But what the epidemiology at somewhat higher doses shows is, and this is done for the ICRP composite Euro-American population, so that's composed of 3 Euro-American populations. You can do a similar thing for the ICRP Asian populations, 4 different populations. This shows the age and sex dependence of risk, age and sex at exposure, different for different tissues. With generally, of course, greater risks at younger ages, but not uniformly so for different organs and cancer types. But what ICRP does with all that information is derive what are called nominal risk coefficients for stochastic detriment for either the whole adult population applied to workers or the whole population applied to members of the public. So these are the the sort of familiar values of detriment of around 5% per for the population. And it's these values of detriment that effective dose relates to. So we've already seen the steps in the calculation of effective dose. So we're starting off with a scientific quantity, and then we're making rough adjustments on the basis of the different effectiveness of different radiation types to arrive at equivalent dose, and then we're summing the equivalent doses, making rough adjustments in terms of tissue weighting factors for the contribution of different organs and tissues to overall detriment. And as you see, and you already know, both equivalent and effective dose are expressed in units of sieverts, and this has caused quite a bit of confusion. An example being after the Fukushima accident, people not really understanding, as a member of the public, politicians, media and so on, not really understanding why there's this very large difference between doses quoted, say for a thyroid dose or effective dose. So the task group is proposing, and it is very much a task group proposal, and for discussion by ICRP, is the discontinuation of equivalent dose as a separate protection quantity. So this would avoid this confusion between equivalent and effective dose. And there's the example here of, again, of iodine. So an effective dose of 40 millisieverts, or the thyroid dose of a sievert, what we're suggesting is you would refer to the thyroid dose in grey, and then that would be easily distinguished from the effective dose. And this also avoids the confusion between equivalent dose, the protection quantity, and dose equivalent, the operational quantity used as a measure of effective dose for external sources, as we've already heard. Now, currently, equivalent dose is only used to set limits to prevent deterministic effects, and the more appropriate quantity for that is absorbed dose in any case. We don't believe that if we used absorbed dose in grey to set such limits, there would be any need to change the numerical values of the limits. So that's a task group proposal. Moving on to the second issue, which is this issue of calculating dose, effective dose to different age groups. ICRP, as we've already heard, calculates dose coefficients for different age groups, children beginning with newborn up to 15-year-old, and also doses to the fetus and breastfeeding infant following intakes of radionuclides by the mother. And in each case, we apply, we use in the calculation of effective dose the same set of tissue weighting factors. And so people have questioned this and so, well, surely they don't apply to all these different age groups. Well, if we look at the tissue weighting factors and just look at the bottom set, but the same applies to the ICRP 60 values, they're a very simplified representation of relative detriment values that are derived from the epidemiology. And only roughly correspond to those detriment values. So they don't really apply at any particular age in a correct sense. So I think this comes back to the fact that effective dose is not a scientific quantity and it's not correct for any particular age group. And what we're doing when we calculate dose to different age groups is doing that for comparative purposes, to see whether the dose at the younger ages might be greater than the dose for the adult. So particularly in public dose assessments, we look to see whether the representative person calculations should be done with a different age group from adult, because that would provide a higher dose assessment. The same applies really for the consideration of doses to the fetus. And looking at the sorts of calculations that we've done and the dose coefficients we have, they show that it's only in a relatively small number of cases that it's likely that you would need to consider dose to the fetus. And these are cases where the dose to the fetus is substantially higher than the dose to the mother, because we're talking about radioisotopes that concentrate in the developing skeleton. So there's this concentration and therefore higher doses. And this use of effective dose in this way as a protection quantity should be seen in the context of the use of constraints and reference levels that apply to population groups, and in this case all members of the public, and used in the process of optimization that provides a pragmatic and workable system of protection. Going on to the last of the three topics, this is applies particularly to the use of effective dose in medicine. So for the use of X-rays in medical examinations, there are obviously a number of measured quantities according to the procedure, the examination, and it's clear that for many applications it will be the measured quantities that will be used directly for surveys, for the quantification of diagnostic reference levels and so on. But in situations where the dose distribution between different procedures is different, then effective dose provides a very useful measure for making comparisons in those cases. This has led to suggestions that actually effective dose isn't the best quantity to use, because we can do better than that. And this is promulgated by particularly David Brenner in the USA, the idea of using a quantity effective risk, in which you can use age and sex specific risk factors and apply those to the calculated organ doses to calculate a quantity called effective risk. So is that an improvement? So I think this comes back to the fact that we can measure the dose accurately, but we don't know the risk with certainty, and obviously with increasing uncertainty the lower the dose. So say effective dose is a useful risk-adjusted quantity, but we know that the associated risks at low doses are uncertain. So effective dose, effective risk, we consider to give a false impression of the reliability of risk estimation. However, can effective dose be used to provide a rough indication of risk? And before we answer that question, I just want to show you some results from a study that was done in the UK by Barry Wall and colleagues. What they did was look at organ doses and effective dose for a range of medical X-ray examinations, and they then calculated the risk from the different procedures using the organ doses and age and sex specific risk factors, using those Euro-American risk data that I showed. and then express that risk per unit effective dose for each of the procedures. And these are the sorts of results. And obviously, we've redone the calculations as well for the Asian composite population to show the difference. Very similar pattern, but some differences. So you see, depending on the examination and the organs that are exposed as a result of those examinations, you see a different pattern of the age response in terms of the risk per effective dose, with the obviously higher risks at younger ages and lower risks at higher ages. And that shows the same for females, somewhat different values, different risks to different tissues. And this is a tabulation of those sorts of data for different types of examinations. So really, you're looking at some deviation from that number of around 5% perceivert applying in middle age or young middle age or whatever you call it, 5% perceivert at 30 to 39 years of age, factors of a few higher at younger ages, a few lower at higher ages. So overall, what the task group concluded was we believe that effective dose can be used with care and in context as a rough indicator of possible risk from medical examinations. And in doing so, you might wish to consider the fact that risk might be somewhat greater at younger ages and somewhat less at older ages. But also in doing so, the uncertainties need to be recognised, and particularly when you're going down to lower doses. And this isn't and shouldn't be regarded as a substitute for risk analysis, where the organ doses would be taken and age and sex specific risk factors used to calculate risks for a specific population group, with due consideration to the extent that is possible of uncertainties. There are a number of other issues that are considered in the report, and guidance given on these issues. I won't say anything more about it at the moment, but it includes consideration of collective effective dose. This is very much an initial stage, and I say the report at the moment is task group proposals for discussion within committees and reconsideration by the task group back to the committees. So it's an early stage of development. Thank you.